Thank you for joining us on this important discussion this morning on the need to address childhood trauma. I want to first thank our Congressman, Representative Danny Davis, for sponsoring this important legislation that we will highlight this afternoon or this morning with regard to some of the supports that are absolutely necessary and why this topic is so important with regard to childhood trauma. So we are expecting Representative Davis to show up. So when he comes to the room, we'll just pause here with our speakers. But I want to introduce myself. I'm Wendy Ellis. I'm at the George Washington University. I run the national collaborative called Building Community Resilience. Where we work with local communities, their healthcare, public health, and multiple sectors to really get to the root cause of community and childhood adversity. So I'll talk about that in a little bit detail. But first off, I kind of want to set the stage for you with regard to what you'll hear from our speakers. When we think about childhood adversity, the many facets of that, where it shows up and how it shows up. So, we've heard, if you're familiar with the average childhood experiences studies, thinking about those individual traumas that children experience, whether that is witnessing domestic violence or a parent that has been incarcerated. But as we grow to learn more about that science, we understand that those traumas that children experience go well beyond just what's happening within that household. It has everything to do with the community in which they reside. And so when you think about, outside of just thinking about abuse and neglect, when you think about personal violence and community violence, some of our own federal statistics that have been collected by the DOJ and CDC, the National Survey of Child Exposure to Violence, shows that 25% of U.S. children witness violent crime in 1 year. That's 1 year statistics. So every year, at least 25% of our children, 1 in 4, are experiencing or witnessing some sort of violent crime. So that begins to help you to understand that we're not just talking about, unfortunately, what a child may suffer from a personal injury, but also what they may be witnessing in their home with their loved ones and other community members. And that more than 55% of our children are experiencing personal injury of some sort themselves. So that begins to think about, well, where is this occurring? Because this can't all be occurring in our households. Well, some of it, unfortunately, is occurring within the systems that are to be protecting our children. So think about this. There's violence that is occurring in our schools, in our classrooms, and foster care, unfortunately. There's violence that is attributed to being homeless, which we have a rising number of children living in poverty, living homeless. And then, of course, with our opioid crisis, and the abuses and neglect that are associated with that. So this begins to help you to begin to think about not only where our children are suffering, but how it begins to express itself in all of these various environments. So when we think about the vulnerability and its association with adversity, really begin to think about that root cause of these long-term disparities that we see. So as I spoke to some of those factors that are associated with poverty, the violence and homelessness, these things have been in the science of adverse childhood experiences also tied to things that get under our skin. So we begin to see the health outcomes that are associated with ACEs. So thinking about the higher rates of depression for individuals who have a higher ACE score, for individuals that have a higher rate of alcohol, illicit, and prescription drug abuse. And I think you'll see this later in my presentation, but I think this really does begin to inform what we see with our current opioid crisis. With regard to individuals that have a higher rate of ACEs are also associated with having a higher susceptibility of opioid abuse, literally self-medicating themselves, right? So I think I'm preaching to the choir here, but I want to make sure for those who are listening to us on the live stream, really understand, the full context of what we're discussing this morning. So as I spoke earlier with regard to violent crime and school performance, can you imagine if you're witnessing this level of crime? How in the world are we expecting our children to be able to focus in the classroom? If they're coming to school hungry, if they're not sure what they're going to walk into when they walk out of that classroom, how can they be expected to focus? So when we see some of these negative behaviors that are occurring in our classrooms, that our children can't sit still, that they can't focus, that they seem to be disruptive, that they're quick to anger, it was really, it's not necessarily asking what is wrong with you, but Johnny, Jill, what has happened to you? And so you'll hear from our educators on the panel today that will talk talk about exactly what does that look like in a classroom when you have a child that has had these high levels of adversities, these exposures. You know, what does that challenge present to our educators, and what are some of the supports and some of the strategies that are being employed to address this? So with this opioid crisis, obviously, you know, we have to look beyond what's happening to that individual who is overdosed and really think about the ripple effects. So in 2014 in Illinois, opioid overdoses actually outnumbered the number of all gun-related deaths combined. So just pause and think about what we see in the headlines when we associate Chicago and gun crime. But to understand that that's just the tip of the iceberg. That you actually have a much larger crisis that's occurring with relationship to the opioid overdose rates. And that's not just happening to that person. As we look at our rates in the CDC, particularly the CDC statistics that show that over the course of the last 14 years, we had the opioid, men have always outnumbered or outpaced women with regard to opioid deaths, but that gap is closing, and it's closing pretty rapidly. So you have to think about what's happening to those children, because typically, you know, if something happens to dad, moms have been able to pick up and move forward, and you know, you have that tradition of single mothers always, you know, pulling it together. What happens when that single mother is gone? What happens when it's grandparents that are trying to take care of these children? That our systems, unfortunately, don't provide the same level of support, financial support for kinship care. So you have grandparents that are on fixed incomes that are trying to support the orphans of their own child's overdose that can't do that. So it's no wonder that when you see in Ohio, the epicenter, literally, of our opioid crisis, you have 7,000 placements for 14,000 children who are waiting. I'm just gonna let that hang there for a moment. So when we talk about childhood adversity in the opioid crisis, as you can imagine, we've had a 5-fold increase of infants that are being born drug dependent. So what does that mean? Again, let's not just think about this singular point in time and what's happened to that infant, but the longitudinal impacts of this that will show up in education in 2 or 3 years when that child's going to school, that will show up in 5 to 7 years, perhaps in juvenile justice. We know the trajectory of children that are born behind the curve with regard to obstacles that are in their way. So you can begin to understand the neurological and the biological impacts that are happening to these children across our country at an increased rate. So no, it's not just the county morgue that has a crisis right now. We have a coming crisis in education, a current crisis in foster care and child welfare, and we have a crisis that's on the verge for our juvenile justice system if we don't do the early intervention now. So these are the states that have the significant increases. And one of the things that I want to point out to you is this isn't a Southern issue. This isn't a Northeastern corridor issue. This isn't a coastal issue. This is a true American issue. It cuts across regionally across our country. And it's also similar to what we see with adverse childhood experiences. Again, adverse childhood experiences, in one of my previous briefings, I pointed out the fact that adverse childhood experiences occur pretty flat across all race, all economic, all education levels. Yet we know that the outcomes for individuals are quite different. So that begins to speak to what's happening, not what has happened to that person, but what's happened after that exposure. So that begins to speak to, we understand some of the supports that will make the difference between having a high ACE score and being completely dysfunctional, and having a high ACE score, like myself, and being quite functional and productive. And it speaks to the supports that are in the community. So there's a responsibility here for us to think about this foster care crisis, the increase in the children that are in our state systems, and how do we respond? How do we think about a place like Cincinnati, Ohio, where Monica Battle, one of our speakers here, will talk about? When we see this increased need for children that are waiting for adoption since our opioid crisis began, and yet our systems have not yet been able to respond effectively because there isn't the ability to be able to coordinate and collaborate across systems. So it's not necessarily asking for additional funding, it's asking for a helping hand across systems that are also responding. How can we coordinate those efforts? And that's an important piece of the legislation that Danny Davis and colleagues have brought forth, to think about how can we work smarter, not necessarily with more money, but work smarter across sectors in a way where we can be much more effective in responding to these crises. So when we think about foster care and childhood trauma, one of the other things for us to think about is, again, we're talking about child welfare. And yet this system, unfortunately, the way it's designed, the way that we deliver programs, actually adds trauma on top of children who have already experienced trauma. Let's face it, if you're in foster care, things haven't been rosy. Something has occurred in your life that is traumatic. If it's just that ace of being put in foster care, that's significant in itself. So we really do have to ask ourselves, if we're able to send individuals off to war and they have a lower rate of post-traumatic disorder than the children that are in our state's care, there's something significantly wrong with that system. So those are some of the statistics, the police statistics with regard to children that are in our best care. And obviously, those that are in child welfare and foster care, they don't go to work thinking that I'm going to make sure that this child lives in poverty their entire life. That's not their intention. Most people that are working in child welfare and foster care are going to work there because they really want to make a difference. Their heart is there for the babies. Yet it's the systems that the way that programs and policies are designed, much like I said, the kinship care, who would want a grandparent to live in poverty, not be able to put food on the table if they want to be there for their child? So those are some of the things that we have to really critically analyze and think about, what can we do better with what we have? So what I've described to you by pointing out the opioid crisis, by thinking about the many facets of diversity, is what we call in the Building Community Resilience Collaborative as the pair of ACEs. So it's not enough to look at those individual exposures, the traditional 10 ACEs, areas of ACEs, but to think about this as a tree. And so those individual ACEs are like the leaves on a tree. It's what we will see, what becomes abundantly obvious when a child presents themselves in a school setting, in a hospital setting, in an emergency room, unfortunately, or just in a play group. Those things are abundantly obvious that something's not right here. But what we don't necessarily see, just like with a tree, we don't necessarily see how deep those roots are. We don't see what's planted below the soil. But very much so, this represents the soil in which our communities are rooted. The soil in which our communities are rooted, in which our children are drawing from. So when you have a soil that's poor in the nutrients around violence, that's what's being fed is whether it's discrimination or those factors associated with poverty, whether there's major community disruption, which we're again seeing across our entire country when we think about gentrification, revitalization of our cities, revitalization that is not coming in an equitable fashion because we have individuals that are at the lower end of the economic spectrum that are being pushed out of our neighborhoods. You see that here in DC, we see that in Portland, we see that across the country. That in itself is a traumatic experience. So we have to think about this in a holistic fashion. If we can't expect to do a point of service, whether that's in the foster care system or in schools or in the hospital or clinic setting, and send folks right back out to feed off of this very poor soil. So this begins to help you understand what we're talking about, how we have to respond to these multiple adversities in a multi-sector fashion. So this is just quickly to give you sort of an analogy. We found it to be quite helpful with folks to understand that when we talk about these things, this is the culmination of toxic stress. When you have those adverse childhood experiences occurring in the context of adverse community environments, unrelenting, without buffers, it is absolutely, that's toxic stress. And just like the branches on the tree, it has the same effect of pruning those branches. So what you see on the top is what a healthy development should occur. There's this branching that occurs when a child is in a vibrant community, when it's being nurtured, when it has someone that's loving, it has new experiences on a regular basis. When that doesn't happen, it's just like taking shears to a tree and it's pruning those branches. So when Monica sees a child that can't focus, that can't sit still, that isn't developmentally on track, she understands there's some branches that have not been allowed to grow. And this is going to absolutely impact this child's academic performance and their trajectory in life. So building community resilience quickly, we're in 5 cities across the country where we're doing this work on the ground, where we're working with clinicians, public health, child welfare, juvenile justice, and our city managers to think about how do we come together with the resources that are already being brought to bear, not duplicating, but working more effectively together to address these issues. What we've learned so far in the 2.5 years that we've been doing this, collaboration is extremely hard. Extremely hard, but it's worth it. And we've got the success stories to talk about it. You can go to our website and see some of the projects, the demonstration projects that are going on across this country. The data sharing across agencies is absolutely important so that we're doing informed work, targeted work, and that we're working with communities. So we're sharing our resources not just across agencies, but with community and providing a community voice to do this work. That education, foster care, child welfare, public health, juvenile justice are critical partners in this work on the ground. So House Resolution 1757 that was introduced by Representative Danny Davis, the Trauma-Informed Care for Children and Families Act fosters this type of collaboration across sectors and with community coordination. It would help us to improve coordination across federal programs, support a trauma-informed workforce. Again, that critical question, that flipping of the question of, what is wrong with you to what has happened to you is so important, but we have to train our workforce. Those that are on the front line, we have to give them the tools and resources to be effective in responding to these crises. And then the support for the innovation around prevention and care and incentivizing working smarter. Incentivizing working smarter. Making sure that we're working with the best that we can with those resources that we have at hand. So there was a companion bill for 1757 in the Senate that was introduced by Senator Heitkamp, Durbin, and Franken. It's Senate Bill 774, so we have bicameral support for this effort. And I will say this area around trauma-informed care and trauma-informed practices has been one of the few areas where we actually have some bipartisan support. Imagine that. Yeah. So yes, this is something that actually, resonates, no matter what your stripe may be, your political stripe may be. And I think that's because we're all about the babies. So I want to quickly introduce our speakers. We have Dr. Acosta, Olga Acosta-Price, who's an associate professor in the Department of Prevention and Community Health at the George Washington University. And she's also the director of the Center for Health and Healthcare in Schools, a national resource and technical assistance center committed to building effective school health programs. Catherine Laren is the acting director of the U.S. Government Accountability Office and a member of GAO's Executive Candidate Assessment and Development Program. Ms. Laren has served as assistant director in GAO's Education, Workforce, and Income Security team, led evaluations and research studies on a broad range of issues affecting low-income and vulnerable populations, including elementary and secondary education. Principal Monica Battle has been at the helm of Cincinnati's College Hill Fundamental Academy since 2013. Over her 19 years in education, she worked in classrooms even here in the District of Columbia before returning to her hometown of Cincinnati to take on a leadership position in schools that serve some of the city's most vulnerable children. Principal Battle's work exemplifies the need to recognize that teaching and learning are in rapid evolution and must take into account new technologies as well as the need to adapt to community context in which our children live. Whitney Gilliard entered foster care at the age of 14 after enduring years of physical and emotional abuse. The aim of foster care is to lift our children out of abuse and provide nurturing and stable environments. But as Whitney will share, all too often, the very system that is designed to heal life's hurts can be the source of new and worsening trauma. So I am going to turn the panel the discussion over to Olga. And if you want to just come on up. I just lost you. He's doing really well there. Yes. Give me just a second here.
Well, I'll take the liberty of going ahead and starting because I actually want to just first say that I'm honored to be with you, and thank you to Wendy and to her team and to all of you for the time that you're taking to be with us today. I appreciate being invited. I in addition to the statistics that Wendy shared, I actually wanted to start with a quote, which I'll read to you and it'll show up at some point, but of a voice that, a young person's voice that we, a snippet of her life that, again, we're gonna have the pleasure and the honor of hearing from Whitney, and so I'm glad that she can be with us. But I think it underscores and it illustrates for us what those roots look like that Wendy was talking about, the depth and the chronicity of adversity that many of our young people live with. The quote from this young woman says, "My whole life is stressful. I ran away from home. There were like 13 people in that house. After a while, you know, there's not enough food and everything for everybody to be there. One winter we had no heat. We had no electricity. We had no water. It was bad." Unfortunately, what we know is that that is not an isolated case. There are too many of our young people in the United States who live in conditions like that. And that in and of itself are some of those impoverished conditions increases their risk and our risk for exposures to a number of adversities. What we know from the Southern Education Foundation report that was released a number of years ago is that now the majority, 51% of our public school youth meet criteria for free and reduced lunch, which is our proxy for poverty. So we have the majority of the young people in the United States attending public school who have a greater likelihood of daily stress in their life related to disadvantage, related to not having the kinds of resources that they need. Children do not leave. Oh, yes, yes.
So thank you. We're gonna pause here. Congressman Davis, thank you so much for joining us. If you wanna, you had some remarks?
Yes.
Thank you very much. I'm delighted to see all of you. And even more delighted to be here. And let me thank everybody for coming who did in fact come, because I think what we are dealing with here is one of the more important things that our society needs to do. And we can't let it go by without addressing it in a very serious way. Therefore, I'm delighted to join the Congressional Foster Youth Caucus, the George Washington University School of Public Health, and the Campaign for Trauma-Informed Policy and Practice in holding today's briefing. Today, we are hearing firsthand from experts and youth about how we can help children and their families who have been exposed to trauma be healed and be successful in school, work, and life. I've partnered with my colleagues, Representatives Robin Kelly and Sherry Bustos in the House and Senator Dick Durbin in the Senate, to introduce the Trauma-Informed Care for Children and Families Act. More than 1 in 4 children and adolescents experience a significant trauma by adulthood. When children experience traumatic events like child abuse and neglect, stress alters the developing brain, which can impact social, emotional well-being and force children into survival mode. A child's natural response to this trauma may result in difficulty paying attention or regulating emotions that often are overlooked or misunderstood in a school setting. This can lead to school suspensions, poor student achievement, or escalation of conflict. Our bill provides comprehensive system reform to support these children and their families. Research indicates that over 70% of children who receive mental health services access these services in their school. Social emotional hearing in schools bring effective interventions into the school setting to ensure more children learn coping and resiliency skills before their symptoms escalate. A key provision of the bill would improve pre-service training programs to prepare educators to work with students who have experienced trauma. We include incentives for the development of curricula focused on building teachers' trauma skills related to the identification, support, interventions, and discipline. Our bill has been supported by over 50 organizations, including the National Education Association and the Child Welfare League of America, two organizations' expertise in the field of child welfare and education. I'm excited about the talented experts that we have with us today who are sharing their wisdom and best practices proven to address the mental health needs of children and families involved in the child welfare system and to reduce absenteeism due to trauma exposure in our public schools. And just to note that personally, I have taught in one of the poorest, most undesirable communities and neighborhoods in North America, an area called North Lawndale in the Chicago area. I taught in a public school setting where children who came directly from that community and children who had been incarcerated in the Illinois Department of Correction many programs for many different reasons. And that community has been an integral part of my life and my work for the last 40 years or so. I also had the experience, unfortunately, recently, of having a grandson who was murdered and having a granddaughter who was there when he was. She has managed fairly well, but she also continues to experience difficulty. She's 17 years old. She is a senior in high school. Her brother was 15 years old, and of course he would be a junior in high school. And their friends, all of them have in fact been impacted very seriously. And there are times when they reminisce and when they talk about things that they do. I'm also a mental health professional by training in terms of having been a psychologist and having my own counseling service at one point. And I can tell you that mental health is one of the greatest needs of a public health way that exists in our entire society. And so the work and interests that all of you are doing, the interest that you are showing, is helping to lead a nation to another level of commitment to understanding the mental, emotional health needs of our population. So again, I thank you very much, and as all politicians around here do, we're always running from one meeting to the next one. So thank you for being here. I'm leaving my walking stick. We have a little mental health.
Oh, okay. So we're gonna do our best to try to describe some of the slides that I had for you.
Try
Magic,
again.
magic. Okay, terrific.
There you go.
Yay! And actually, to a slide that is, I can attribute to a partner organization, the Center for School Health and Education at the American Public Health Association, that I think illustrates again the severity. I would amend something that Wendy said earlier, that the crisis in education is not a future crisis. There's a current crisis in education in terms of the lack of capacity and the lack of appropriate services and knowledge around how to address the depth of need that presents itself at the school door. These issues do not, don't present themselves and just sort of disappear as soon as you start class. They absolutely do impact the learning environment. As we already know, the prevalence is quite high. 1 in every 4 children attending school is estimated has been exposed to a traumatic event that we know increases the likelihood of having difficulty. The other issue, as Representative Davis very much keyed up for me, is that the way that that presents itself is in the expression of particular mental health difficulties, in symptoms of depression and symptoms of anxiety, post-traumatic stress, which are very normal reactions to these abnormal conditions that many of our young people are living through. And so what this slide does is help us understand that mental illness in adulthood, we know from epidemiological studies, actually show up very early in childhood and early adolescence. We know that half of lifetime diagnosable disorders in mental illness start by age 14. First symptoms of difficulty start by age 14 on average, and about 75% by age 24. What's important also to note from this chart is that the age of first symptom, there's a discrepancy between the age of the first expression of the symptom and the age of first diagnosis, which in many of our systems, and particularly the behavioral health system, is when the traditional mental health services can be provided, when you've now had enough suffering that you meet criteria for medical necessity. But often that's very late. If you look at how long young people have to wait to access that care. And what we know is that, again, these adversities are pervasive and that health and education are inextricably linked. Poor health is linked to poor education is linked to poor health. And what this slide helps us do in this analysis from child trends is to bring home the fact that the greater the exposure, the greater the number of adverse conditions that a young person, and in this case it was a parent reporting on a young person's, their child's life, that the greater the number of ACEs, the greater the likelihood they would be disengaged and failing from school. Okay, so that association is very real. And there are 2 main pathways, 2 general pathways that actually can help us understand those educational disparities. One has to do with the individual coping and symptoms that we see among young people, that there are changes, as we know from the burgeoning neuroscience literature, in brain development and functioning, in the processes and in the structures of the brain that are impacted by exposure to trauma and ongoing chronic exposure, that there are lags, as Wendy had talked about, in concentration and memory, in social development, in cognitive development, and behavioral health, that absolutely are necessary to succeed in school. So these are skills that are necessary to be successful and to access your learning environment. But also there are ways that unfortunately the education system has historically also pushed out individuals that have had difficulty. Again, because the system has not had the capability, was not designed to be a health system. It was designed to be one whose aim was to educate. Well, we've now come to realize that we cannot separate these things. A healthy young person is one who will be able to learn, and therefore educators absolutely get that. But that doesn't mean that they have the requisite skills and knowledge and experience to know what to do with that. So what we're finding is that young people, particularly those with mental health and behavioral health problems, are more likely to be disengaged from school, to be expelled, suspended, drop out. We also know that although very prevalent, unmet mental health needs are significant and access to care is unfortunately very limited. What was alluded to, and is we do see over and over again, is that when youth do get the care they need, that most often happens in the context of schools, school-linked or school-based care. That is incredibly important if we think about the reach of schools. Schools there are 56 million children in the United States who go to school 7 hours a day, 5 days a week, 9 months a year. People under the age of 18 make up 24% of the US population. So we're talking about almost a quarter of the population under age 18, many who we've already shared statistics have a great level of vulnerability and are maybe not meeting healthy milestones that again are making it very difficult for them to succeed in school. But school and education is not only a location, they are dynamic systems and very much influential because they can be significant parts of solutions that we can provide and that we can offer in community. Why is that? Because what I like to call instead of just being the place, there are other P's. What are the other P's? There's a tremendous number of influential people who work in schools. Teachers, administrators, health providers, parents, volunteers, who create relationships and maintain relationships with young people which are very healing and which very much can, in many cases, reverse the impacts or at least mitigate the impacts of trauma and stress and adversity. There are a plethora of programs, as principals can often tell you, sometimes too many, that are available in schools. Health promotion, around skill building, around prevention, around early identification, treatment that are offered across the spectrum of health, as well as practices that have to do with how to maintain healthy school climates. How do you create environments where learning and health can happen, and what are the practices and what are the norms and values that get expressed in schools? And then there are the policies that help establish and maintain those practices, right, at the school district, state, and federal levels. And then we always have to remember, those of us in public health and health, that there's a lot of other priorities, competing priorities that educators and administrators have to deal with around accountability, around pressures to deal with adhering to multiple stakeholders, around the politics that occur in education. And we have to be mindful that although they are essential partners, that we can't expect that they will simply be, again, doors for access to care without also understanding the many demands that are being placed on education. So there are numerous arrangements that occur in schools already, and I think it's important to recognize that again, education and educators have been way at the forefront of trying to figure out how to do this, sometimes by using just the internal resources from within the system, and other times, more often, looking outside of education to other partners, health systems, community providers, ways that arrangements can be forged to allow schools to have the capacity and the skills and the qualifications to actually address the array of services that are needed. One such example is expanded school mental health programs, which is an example of co-locating a licensed mental health provider who often is hired, let's say, by the district, by a government or by a community behavioral health system, but is co-located in the schools to expand the array of what is available, and not just in terms of treatment, which then often these individuals are trained to be able to do effective evidence-based treatment in schools, but also to address the systemic issues and the early identification that needs to happen, and that again, schools are not often prepared to know how to do well, given that they are often shaped to look at educational, learning, cognitive kinds of issues, and not necessarily on what to do around the behavioral emotional issues that arise. Similarly, it's important to talk about the fact that there is a growing interest and a depth of knowledge being built around trauma-sensitive schools. And these are some of the essential elements, a very dense slide, I apologize, but certainly a number of resources and experts even here in the room who can talk more about that. But just to highlight a number of them, what we're talking about are, again, changes to the system that allows the educational system to maximize learning. And one of the ways to do that is to, again, increase the shared understanding of what adverse experiences are, how common they are, and how it impacts learning. And that often is done through professional development. The school supporting all children feeling safe and physically, socially, emotionally safe through whole school approaches, social emotional learning, positive behavior and intervention supports kinds of approaches. And the needs to offer an array, everything from crisis intervention to social services supports in and out of the school. It's also the awareness, I want to say, of the prevalence and the impact of secondary traumatic stress on teachers. It's really important that we really recognize that part of why we're having such difficulty in retaining good teachers has to do with the same issue, the vicarious traumatization that is occurring and the lack of support that teachers are feeling as this key frontline providers. So the ability of school staff to be present and to be part of the healing process that a lot of our young people need is dependent on their own well-being. But we don't have a lot of literature, a lot of programs or understanding of what those best practices are. That is just really starting to get attention now. So my last slide is on, well, what are some of the policy implications then of what I'm trying to say? One is that we need to think about ways to improve the capacity of the adults to effectively identify and support young people exposed to high levels of stress, both through pre-service opportunities and through professional development opportunities. To think about promoting positive school climates and trauma-sensitive practices in schools and providing guidance to schools around how to do that. Particularly ESSA offers the Reauthorized Education Act, Every Student Succeeds Act, particularly the School Quality and Student Success Indicator of that law requires states to essentially identify a non-academic indicator for accountability purposes that must be included in their state plans. That offers an incredible opportunity for states to identify things around school climate, around social emotional learning that absolutely can impact not just the traumatized individuals who are traumatized, but the entire school population. The improving the spread of school-linked approaches that really are about coordinated and integrated care, full service community schools, school-based health centers. These are models of service delivery and of prevention that are about coordinating resources and bringing together as providers. And finally, to facilitate methods to blend and braid public funds to sustain. I didn't say much about it, but really, we know a lot about effective programs. We know a lot about how to provide them in schools. What we know very little about is how to effectively sustain them. And part of why, yes, it's about dollars. Yes, it's about funding. And we have to give guidance to local communities about, and the freedom to figure out how to braid and blend funding from various sectors. But it's also about how to institutionalize these practices in ways where there's a long-term impact. So I will end there. And again, thank you very much. I'm happy to take questions later.
Good morning. I'm going to start by sharing with you why I am so passionate about this work. It was almost 6 years ago today when a young lady walked into my school, and I met with her as a new incoming student that was entering mid-year. My interaction with her and this experience is what directed my mission moving forward and absolutely ignited the passion that I have today to make a difference as an educator in a different way. I'm going to share with you her story. She was 12 years old at the time, just placed in a foster home, and that's why she was coming to my school at that point in the year. She had been neglected by her mother and several other adults throughout her life. Experienced physical and emotional abuse, and just delivered a baby boy a week before she walked through my door. And yes, I am the principal of an elementary school. I sat down with her that day and I was shocked at what this young girl before me had experienced. All I wanted to do was hug her and say, it's gonna be okay. I don't know how yet, but we're gonna help you. I'm so glad you're here. And that's what I did. That was the beginning of my relationship with her. She shared with me her story willingly, and almost once she started talking, she couldn't stop. So it then became my personal responsibility as the owner of this story to try to do something to help her. And she attended classes went back and forth to school for a couple days. We had a security, when you come through the door of the school, they were checking for weapons and such forth. And she had a little backpack, just a normal sized backpack, but in this backpack, she had everything that she owned. It was her life. She had few clothes, few personal items, and a picture of the baby boy that she had delivered. She did not want to relinquish the backpack this particular day to have it searched and gone through, and ended in a little bit of a scuffle, and she was being disrespectful to the adults trying to get the backpack, to the point I was in the office and I heard the commotion and ran out. I was able to get her attention and have her focus on me to kind of calm down and realize, give me the backpack, it's going to be okay. Because of the discipline system, there are consequences for behavior, and that's what I explain to my students. If you do something, there is a consequence. She was actually put up for removal and expulsion. I did go to her hearing and pleaded on her behalf, no, this cannot happen. But this one story is just a glimpse into the window of so many schools. I have 100+ more stories, starting with children as young as the age of 4, 3, 4, and 5. So she ended up staying at our school through probably mid-year next year. Her goal, by the way, was to find a foster home placement that would accept mother and baby. It didn't happen. Her son was adopted by a family, and she did go on to do well. But that's how that phase of her life started. So I'm here today, as you can quite imagine, to build awareness about one of the root causes of underperformance in our schools today. Yes, we are measured by academic performance, but the measures that really matter is being able to get the children where we need them to be available for learning before we can even teach them. I want to talk to you about the challenges that we are faced today with the students not being available for learning. You've heard today about the ACEs and some of the adversities that face our students, in particular in Cincinnati, my hometown. The Center for Disease Control names these ACEs as predeterminants for future health. That's pretty powerful. For most people, it is still an unknown epidemic. This is absolutely a health crisis that we are facing. Because of the efforts of my staff, my district, and we are doing things differently in Cincinnati, and I'm very proud of that. We recognized early on that early intervention, early identification, training is critical. Education is supposed to be the great equalizer in this country. Again, if a child is not available to learn, if we cannot reach them, we cannot teach them. So recognizing that, we decided to see what we can do differently, education differently. My enrollment at my school is 475 students. My district serves 35,000 students. So imagine the small impact that I'm having at my school with my staff, with children. It's just the size of a pinhead, really. The need is great. Students with disabilities represent about 19% of the population. And then when you're talking about economically disadvantaged families, in our district, it's at about 82%. At my school, it's 92%. I want you to think about the possibilities and the impact that we can collectively have when the right support comes together to change the outcome for our students. Our mission at College Hill is to prepare students by giving them the tools they need to carve out their own destiny. The tools and what's in their toolbox has changed. At one time, it was teaching them and preparing them to go on to high school, college, and beyond. Now we're teaching them and preparing them to self-soothe, to cope, to learn how to adapt to an ever-changing situation and world that isn't kind, to build resiliency, identify what their strengths are, and capitalize on those strengths to use them to their advantage. So that when they're old enough to then make decisions for themselves, they have these very fundamental tools that many of us learned just in growing up in our own households. So schools now, we don't just educate children, we really shape, mold, and educate them, preparing them truly to be able to carve out their own destiny and beyond. As a staff, we've partnered with local agencies and groups to increase our understanding. This was one of the first steps that I took. Teacher training was paramount. Teachers are trained educators and practitioners, and they are very good at it. It is a different ballgame when you're facing the crisis that children walk through the doors with. So we needed training. We focused on having a growth mindset with our students and each other, teaching our students to identify their strengths and use their assets, ultimately building resiliency and acceptance. Creating an environment that supports and accelerates healthy student development and academic achievement is our daily goal. We can't change the students' situations, but we can provide a safe place to learn and the tools needed to cope and succeed in spite of what's happened to them. So I'm going to mention some of these practices that you can see evident in my school and other schools across Cincinnati Public. The teacher training program I mentioned, we have also incorporated safe zones in our schools for students and teachers to regroup and de-escalate in the hallways and in the classrooms. This helps build and increase self-regulatory capacity in children while creating safe, supportive spaces for students and staff. We talked about the staff self-care and secondhand trauma. That is also very real. So safe spaces for staff and self-care rooms is something that you now find in our school as well. We also train the students on response strategies and how to assist when in crisis or when another student is in crisis. Peer-to-peer mediation and support is powerful when creating a culture of accountability to self and accountability to others. Multi-sensory experiences for students, both inside and outside of the classroom, are also created. This includes exercise bikes, drawing, play, obstacle courses, finger and foot mazes, and various other activities to re-enter, refocus, and de-escalate. Children that are living at higher levels of stress and handling adversity need to learn these very essential basic coping mechanisms and techniques. We are currently working on adding 2 additional programs that I'm very excited about this year, a music therapy program and a pet therapy program. These programs will contribute also to teaching the self-soothing, calm down, and how to prepare and re-enter the classroom for learning. We also provide the therapy case management on site. I have 5 therapists, and they have a caseload of last year 80, probably this year 90 to 100 students. This strengthens the students' adaptive skills, executive functioning skills, and self-regulatory capacities. The therapists conduct private sessions and come into the classroom and work with the students, families, and peers. This year, we're also adding a component of working with the teachers. We have advisory for social and emotional learning. It's a dedicated time that focuses on identifying and building upon social emotional strengths and character strengths. These small groups in our school, we made them gender-based. and no larger than 15, grades 3 through 6, 45 minutes per week led by the teachers. Amazing conversations come out of these groups. The impact of being more trauma responsive creates a school culture that can meet the individual needs of all of our students. As a result, increasing teacher effectiveness, ultimately accelerating student development and academic achievement. Building resiliency is critical to building a strong academic foundation. The two go hand in hand. We all understand the impact that healthy nutrition has on our children's development. And to this point, we have free breakfast and free lunch programs in all of our schools. This is wonderful. I would argue that this is just as essential to their healthy development. I really want to sincerely thank Representative Davis. I know he had to step away for supporting this legislation. And I appreciate your time and willingness to consider the possibilities for supporting education and educators in this work. It takes collaboration with politicians, researchers, medical professionals, along with practice and field-based groups to make a difference. And in closing, I ask you to consider policy implications of what we are discussing today at the federal level. Thank you.
Good morning. I really appreciate the opportunity to participate in this panel this morning. I'm going to start by providing a brief overview of what we know about trauma and adverse childhood experiences among children who are involved in the child welfare system. I'm also going to talk about how this impacts the services and supports that these children need. And finally, I'll wrap up with some policy implications with a focus on recommendations that we at GAO have made in the work that we've done in this area. In 2015, there were about 430,000 children in this country who were in the child welfare system. And that was a significant increase after steady declines over most of the prior decade. The increase was driven, as Wendy mentioned, largely by the opioid crisis. And as a result, those numbers are probably significantly even higher today. Children enter foster care when they've been removed from their parents for reasons such as abuse and neglect. So almost by definition, children in foster care have experienced trauma and adverse childhood experiences. Additionally, as was mentioned earlier, foster children who can't be placed in the home of a nearby relative are deprived of some of the key protective factors that can help them cope with the toxic stress of trauma. Some of these key protective factors are ongoing continuing relationships with a caring adult and maintaining familiar environments. Sorry. Instead, over half of foster children are placed in non-family settings, and over 40% are placed in foster care when they're under the age of 5, which is an age at which they are particularly vulnerable to the adverse impact of trauma. So it's not surprising that children in foster care are more likely to have special needs and more likely to have mental health conditions than children in the general population. In a survey that was done in 2008, 42% of children who had been removed from their homes after an investigation into abuse and neglect were found to either have emotional or behavioral problems or possibly need mental health services. Another study found that children placed in foster care are twice as likely to have a learning disability and 3 times as likely to suffer from ADHD. As was also mentioned earlier, trauma leaves children very vulnerable to a range of mental health conditions, including post-traumatic stress disorder, depression, and other mental health issues. So turning to services and supports that are needed for this population, I'm going to focus on 3 areas where GAO has done work. First is placing children in appropriate settings. Second is going to be maintaining that stability and continuity that I mentioned as protective factors. And third is mental health services, and there I'm also going to focus on the use of psychotropic drugs among foster children. So first, with regard to placing children in appropriate settings, federal law requires that foster children be placed in the least restrictive, that is the most family-like setting that's available and that meets their needs. But past GAO work has shown that states have faced challenges in meeting this requirement. In 2016, we looked at state efforts to place children in family-based settings rather than in congregate care, which includes group homes and institutions. We found in the states that we looked at that there was clear progress in reducing institutionalization, a decline of 47% between 2004 and 2014. And this was the direct result of state efforts to address this concern. There was more oversight of decisions to place children in congregate care, and an increased emphasis on recruiting and retaining foster care families, including the use of an emerging model called therapeutic foster care, where families are provided with additional specialized training to deal with the mental and emotional concerns that children who have experienced trauma face. However, in some states, up to a third of children we found were still being placed in congregate care settings. So with regard to maintaining stability and continuity, we did some work looking at the Fostering Connections Act, which is federal legislation that aims to maintain family connections as much as possible for foster children through efforts such as requirements to notify grandparents or other adult relatives when a child is placed in foster care, to the extent possible, keeping siblings together when they're placed in foster care. And if possible, keep them in the same school that they were attending before they were placed in foster care. We found that states were using various strategies to implement these requirements, but they really did face challenges, particularly in having sufficient placements to allow them to keep the siblings together and to keep kids in the same schools. So now I'm going to turn to mental health services. Over the past several years, GAO has issued a number of reports looking at the use of psychotropic drugs among children in foster care. Psychotropics are medications that affect mood, thought, or behavior, and can be used to treat conditions like depression and ADHD, but they also can include antipsychotics. There have been long-standing concerns about the overuse of these drugs, especially because of their potentially harmful side effects. GAO found that foster children were being prescribed these types of medications at rates that were 2.5 to 4.5 times higher than other children on Medicaid. Some of this might be explained by the fact that foster children have greater needs. But when we looked at the patterns of prescriptions, there were some patterns that were very concerning. For example, we found children who were being prescribed 5 or more medications at the same time. We found children that were being prescribed dosages of psychotropics that were much higher than recommended doses. And we found doctors prescribing psychotropic drugs to infants who are under the age of 1. So last January, we issued a new report where we looked at how states were overseeing the use of psychotropic drugs in the foster care system. And we found that states were moving in the right direction in reducing their use of psychotropics. They were taking steps like developing better guidelines for doctors, monitoring kids who are taking more than one medication, and also involving another adult, be that a caseworker or a foster parent, in the decision to prescribe psychotropics and making sure that they understand the risks that were involved and that they agreed with the need. So despite these efforts, we also found that states face continuing challenges in meeting the mental health needs of foster children. We found that 30% of foster children who needed mental health services did not receive them. And to give just one example, we talked to a county official in Ohio who said that they were sharing 2 child psychiatrists across 6 counties to meet the needs of mental health needs of all of the foster children in that area. And even when mental health providers are available, they don't always have the expertise to deal with kids who have experienced trauma. So I'm going to talk just briefly about policy implications. So at the federal level, there are various agencies, including SAMHSA, the CDC, the Administration of Children and Families, who've all played a role in disseminating best practices, in offering technical assistance, and in funding important studies, such as on the use of psychotropic drugs. But in all of the work that we've done in this area, we've concluded that much more remains to be done to improve the outcomes for children in foster care who've experienced trauma. With regard to placing foster children in appropriate settings, we've recommended that HHS do more to support state efforts to reduce congregate care. And with respect to the psychotropic drugs, we recommended that HHS do more to promote collaboration between child welfare agencies, Medicaid agencies, and other stakeholders, and consider ways to better share information on medication oversight. Stop that.
Hi, I want to say thank you for everyone for the special opportunity today. A thank you special to the congressmen, senators, representatives, and the staff for being here. And of course, to Representative Danny Davis, because I was here with him for Shadow Day, and his continuous work is something that's refreshing to see on Capitol Hill, because he's fighting for children who he serves. If I get emotional, just excuse me. And of course, for my husband's unconditional love and support. My story is unfortunately the same as everyone else's in foster care. I entered care at the age of 14, and I remained in care till I was 21. I'm 23 today. I endured 9 years of physical, sexual, and emotional abuse prior to entering care. I walked into foster care with a trash bag of my belongings, and I've lived in a total of 18 placements. At 17, I lost my father to cancer, and I never knew who my mother was till he died. I was petrified when I entered care. I struggled in school, and I was reminded every day by the lack of quality education I had that I will never be successful in life. I struggled with on and off medication, and more than the desire to want to know why my life was so bitter, I wanted to ask the doctor who gave me my first handful of psychotropic pills at the age of 14, do you know what you've predestined me for? As I've tried to salvage as much as I can to normalcy, the journey of foster care left me battling with on and off medication roller coaster rides and multiple failed suicide attempts. And the fear as I scrounged within myself that this is what my life is like, and the never-ending answer to the question, am I crazy? In foster care, I was afraid of being myself. If I cried, I was given a pill. If I screamed, I was pushed to these quiet rooms that were supposed to be a place for kids to calm down, but it was just as good as solitary confinement. And when we were in there, all we thought about was the trauma that led us to there in the first place. If I had a bad day and I told anyone, the word would somehow travel to my psychiatrist, who would then push for more pills for me to take. And get this, if I refused my medication, I was punished to my room for 72-hour room confinement. Undergarments are prohibited, and if you're gonna take a shower, be prepared to take it without privacy. I was 14. It's called Suicide Watch, and I was conditioned that if I refuse the drug, I will be punished. During school day, and I remember an instance that I was never told when my treatment team meetings will be. I will be randomly pulled out of class, and I had to hear that no foster care, there's no foster homes available at the time, and you're also going to have another set of medication because you can't seem to cope with your environment. So after hearing that, I was pushed back into the classroom, expected to carry the day as is, do your schoolwork, listen to your teacher, and try not to cause a ruckus. And when I did, it happened all over again. Every time I had a new social worker, the translation of my care would change. So it was a new introduction, which means a new retelling of my story, which means reliving what led me into foster care. I am not the only person who's gone through this. Thousands in foster care until today are still undergoing this horrendous cycle. It is re-traumatizing us, and there's something horribly wrong with the system, and it is costing our life as we go by trying to find a solution. Medications are not the problem. I'll make that perfectly clear. However, the problem lies within what I like to call medication without representation. When I was a minor, I had little to no say on how my medications made me feel. And of course, I didn't have parents to speak up for me. The repercussions on how to care for foster youth if they refuse to take their medication have to be reviewed. Reprimanding children who have already undergone an immense amount of trauma is not the answer. It teaches us that without the meds, we are incapable of recovering from our trauma, and the result is addiction. I hope that through my testimony, you get a glimpse of what it's like to be in foster care. And it's pretty scary. It's pretty hard. And I've been through it, and there's a lot of people that are still going through it. I have a son that's 2, and there's somebody as young as him going through it. Children who enter care, just as I enter care, with nothing, but they have a whole lot of trauma. I hope that after hearing my story, every child is given a bag of hygiene and clothing essentials to assist them in their transitions. Children in foster care systems should have designated weeks of the month designed for treatment team meetings and psychiatric reevaluation, because simply pulling kids out of the school day and expecting them to carry on as is with the news they heard is not acceptable. Upon leaving care, all youth should be taught the life skill on how to properly tend to their psychiatric needs. The independent living program should be revised and become structured for cases of child who suffer from trauma. We should implement goals regarding psychiatric care and preventative actions that they can take. Leaving out of foster care, I not only knew how to prepare for myself when it came to psychiatric need, I had to confront a world that was foreign to what I just aged out of. I couldn't hand somebody a binder and say, "This is me, help me." There has to be better care for children leaving the system. Children as young as 2 have gone through what I shared. Children who have undergone trauma should be protected. I have faith and I have hope that with you all coming here today and the team, that we'll find a way that we can together better take care of our children, because it's happening right before our eyes. Thank you.
I just want to personally thank you for your bravery, your resilience. I want to thank those who supported you so that you could be here today. Clearly, Whitney, you suffered greatly on your own, but there were also some supports that had to be there somewhere in your points of life to get you to be here today.
Yes.
And I think that while we wouldn't want to dismiss your experience, I think it's also important for us to think about what were those things that were so important that help you to be the person that you are today, despite all of that. Could you share a little bit of that also?
Yes. So there's the, definitely my GAL was a big role. Having right recruiters to take in the GAL and explain to them that your job is to advocate for the foster kids is number one. Because sometimes the social workers, like everyone mentioned, they do the best that they can to help the children, but the system is so broken and it's hard for them to do their job. So with the help of a GAL, I was finally able to be placed in a foster home. And that foster family is now the grandparents of my son. The independent living program was something that helped me because they were able to give me a stipend at the end of the month, but that should be continuously funded and even better yet, reviewed, more hands-on for children who's undergone trauma. And when I was in a public school setting, I had a panel of other foster kids who designed, it's called the Foster Youth Advisory Panel. And what they were able to do is they were able to hold a training for teachers on how to, if you have foster kids in your public school system, what do you do? And this came up because one day when I first entered a public school setting, a teacher gave me a pamphlet of how to say no to drugs, and it was like as if there's something wrong with me. So having the proper funding and training for teachers to get the help that they need so that they're not constantly battling with this another kid with problems, They're not so overworked and tired, and they know exactly how to handle it.
Thank you so much. And I think what you talk about here, what you point out is giving people the help that they need,
Yes.
right? And so we heard that across this panel here of identifying those things that are working. So not just shutting the light. We certainly aren't here to just shine a light on what's wrong and what's broken, because that's obvious. There are a lot of pieces that are broken, but there are also similarly a lot of pieces that are working. And how do we lift those things that are working? I think it was really important that both Monica and Olga pointed out that some of those best practices that are in place that we can help through this pieces of legislation such as this can help to lift up those programs. We know that co-location of mental health providers does work. We have the evidence that that does work, and clearly our schools are on the front line of this issue. But and supports for educators such as Monica, who are on the front lines doing the best that they can. One of the things I wanted you to point out, though, when you talk about all of those programs, those aren't necessarily drawing away from your academic programs, correct? You're finding, how are you supporting those programs?
That's correct. They're not drawing away from the academic programs at all. We're getting pretty creative because it's been known that teachers and educators, we dig into our pockets and support our students and kids always. So there's a lot of that going on, applying for grants and partners locally, talking to local agencies and partners in Cincinnati that share the same vision and mission, and seeing how they can help us in a school setting.
Thank you. And so, when you talk about supporting children in the school setting, you talk about your experience and how many years of foster care. That also meant that you were probably bouncing around to multiple schools. And I think that one point that Kathy brought out was the fact that the key protective factor for our children are these supports that are familiar and familial. So it's not one or the other, but it really is both. And so the familiarity of a school and that school community, your teachers, is just as important for these children. So when we think about how we're uprooting and moving children from school to school, culture to culture, because the children at your school definitely benefit from a unique program that's not widespread throughout Cincinnati Public Schools. So we want to make sure that we're also thinking about the differences in the culture, the differences in the treatment environments that would help to support our children. So that continuity of placement, as Kathy discussed, clearly is important for us when we think about what's happening within the foster care crisis and how that overlaps with our education system. So we have gone over time. I do want to respect everyone's time, but this has been a rich panel. Are there any? I could take maybe one or two questions. Certainly.
Yeah, I want to raise the elephant in the room because you've all talked about mental health and mental health access to some extent. So everything that's being discussed in Congress is about Medicaid caps or stripping out the essential benefits. How is that going to affect mental health services in the future compared to where we've been in the last 2 or 3 years?
I think my answer you probably know, which is, we're very concerned. A lot of particularly the school-based and school-linked programs and approaches that we very much promote and work towards enhancing are in the least resourced parts of the country, because that's where the need is greatest. And often we're talking about populations that are much more likely to have Medicaid or public insurance. And also for provider types that, where we've already had difficulty before our current situation, having Medicaid reimbursement for school-based services, which not every state easily maneuver. We're having some successes in figuring out the mechanisms and the levers to get that to happen. my worry is a lot of that is stalled, if not being reversed. We're now, going to have, we are worried in the mental health community about essential benefits and about behavioral health and substance use disorders and the potential for some of that to really be rolled back. I don't know what to say about what moving forward will be, except that I think that a lot will rely, particularly locally and at the state level, trying to figure out how to best advocate for how we could come together with the dwindling resources and how we can be creative, which is what we often do in all of our systems, to figure out how to piece together the little bits we have to try to touch as many kids as we can. No great answer.
So one of the examples with regard to how are we creative in creating a little bit more access to services, particularly for vulnerable schools or in populations, is our partner in Portland, Oregon. They have Bobby School there, and they've actually created through Kaiser Permanente, through their community benefits division, their program. They've created a health clinic within the school. So they will be able to serve those children there and where they are. And so that is another one where we think about, again, what are some of the other existing avenues to support these programs? And this is why healthcare obviously is a very important partner in this work, working with them on creative use of community benefit dollars to support these very vulnerable populations. Yeah. So I want to invite Angelique from Representative Davis's office, who wants to talk to us a little bit about the colleague letter.
Thank you, everyone, and on behalf of Congressman Davis, I want to thank you for being here, for hearing about our bill and supporting our efforts. And in that support, we did provide your colleague letter out in the front, and for my staffer colleagues in the room, we'd love for you to take a look at that. We are actively seeking additional co-sponsors for our bill. And also wanted to let you know that we have partnered with Congressman Gallagher's office recently on a House resolution creating a trauma awareness month. So in that bipartisan effort, we're looking to not only create awareness, but to really raise up HR 1757 so that in addition to awareness raising, we can also, put some hard and fast resources into expanding our trauma-informed efforts across all of these important and critical service systems that, as you heard today, really need to work together to ensure that all of our children and families that have been exposed to trauma can be successful. Thank you.
So just one parting thought here. Olga, you mentioned that poor health is linked to poor education, and vice versa. So this is a bi-directional pathway here. And so with that, when we're thinking about how all of these are connected, I want to leave you with the thought that Monica said so eloquently. If we cannot reach them, we cannot teach them. And I'm gonna amend it a little bit. And if we cannot teach them, we cannot expect them to thrive. So go out, go forth, be productive, continue championing this cause. And I want to thank my panel. Thank you for taking your time today to share the story. And again, thank you, Congressman Davis.